So, hello guys. Today we will discuss, I will make a small introduction into today's course, and then you will do practical assignments. We will meet in about 30-40 minutes where will you discuss situations that are uploaded in Moodle. So first and foremost, epilepsy is of course a seizure disorder that you've probably covered in the neurology. And it is defined by tonic, clonic, focal, absence, or myoclonic seizures. And these seizures are usually modulated via ion channels or enhanced inhibitory neurotransmission via GABAergic system. Broadly, we could classify anti-epileptic drugs into cyclic ureas, such as phenytoin, phenobarbital, or etosoximide. And for instance, phenytoin works by blocking voltage-gated sodium channels and is effective for generalized tonic, clonic, and focal seizures. Phenobarbital is another important drug that's used for last line management of epilepsy. Also works on GABAergic transmission and inhibits seizures. Phenobarbital induces cytochrome P450 system and can cause thus lots of drug interactions. There's another interesting drug, etosoximide, in this group that acts on T-type calcium channels and is used for the treatment of absence seizures. Some of drugs are tricyclic derivatives, such as carbamazepine. It blocks sodium channels and reduces glutamate release. Thus, it inhibits generalized tonic, clonic, and focal seizures. Benzodiazepines also work on GABAergic transmitters and block epilepsy. There are also other GABA-related drugs such as pregabalin, vigabatrin, and they also inhibit calcium channels and eventually inhibit GABAergic transmission. There are some drugs that you could call as miscellaneous, such as valproic acid, which is a broad spectrum anti-epileptic drug that inhibits high-frequency neuronal firing and can be used to treat multiple types of seizures, generalized focal and myoclonic seizures. And it is quite often the first line of disease, the first line treatment for major epilepsy disorders, but it has some drug interactions. Also, it has negative effects on the spermatogenesis and also can have teratogenic effects. Therefore, for women of childbearing potential, the valproate needs to be changed to some other drug. Whenever treating epilepsy, note that you need to focus on monotherapy. It is very rarely that you'll see that there are two types of drugs prescribed for the treatment of epilepsy. However, sometimes you switch from one drug to another, so you would prescribe two drugs because you're trying to saturate with another drug. And some very rare patients can actually need the treatment of two drugs, but that's a rare event. All this that we're talking about actually focuses on neuronal transmission. So in epilepsy, we have increased activation of GABAergic neurons, and this is a synaptic transmission. But also next to it, you will see glial cell, because this is to some extent a tripartite synapse. This is where the sodium, potassium channels interact, and also oligodendrocytes interact on the neuronal synapses. And this is the place of action for most of anti-epileptic drugs. GABAergic transmission is one of the most important pathways because it inhibits, when you act on GABAergic transmission on benzodiazepines, you produce, you inhibit GABAergic activation in the brain, and you can treat epilepsy and decrease seizures. And this is why first-line treatment for epilepsy, especially in acute care, actually is based on GABAergic system, and Most important drugs here are like lorazepam and diazepam because they're benzodiazepines acting on GABAergic transmission, and they are used to treat acute onset epilepsy or status epilepticus. Some drugs act on sodium channels, but sodium channels are also they have a lot to do with membrane potential and depolarization, but also the end result is GABAergic transmission. Lamotrigine, valproate, they bind to sodium channels, but by binding to them, they change depolarization and then decrease GABAergic transmission, and this is why they decrease seizures. Valproic acid acts on calcium channels, but also in the end decreases GABAergic transmission. This is a nice graph that shows how all modern drugs act when we treat epilepsy. So here you can see the neuron from which glutamate is secreted, and this is how neurosynaptic transmission works. So you can see that if we block sodium channels, we block the release of glutamate, and thus we block the postsynaptic neurotransmission. So basically we inhibit this seizures. So the same will happen if we will block calcium channels with pregabalin. They also all work in the end by changing the depolarization of the neurons, but in the end they block GABAergic transmission and the secretion of glutamate in the synaptic cleft. And this is how we pharmacologically treat epilepsy. And now there's a small off topic at this point. What we're talking about here is the junction between neurons and synapses, right? But there are such cells like astrocytes and other oligodendroglia that are important in this synaptic transmission. So there is some research, and do not be surprised because I don't know how far will this go, but there are some theories in epilepsy that astrocytes have a potential as a therapeutic target in the treatment of epilepsy and other neurological disorders, including epilepsy. And so astroglia and astrocytes are part of oligodendrocytes, and they act as modulators of the synaptic transmission, and sometimes pathological changes in astroglia can provoke occurrence of seizure disorders and other neurological conditions. There is a plethora of different astrocytes, but they are very important brain cells. And you can see that astrocyte, this is an example of astrocyte that is secreting glutamate to activate neurons and also acts on GABAergic neurons. And actually some of the treatments are targeted on the astrocytes and specifically on GFAP expression. Sometimes it has been previously described that astrocytes in epileptic brains have a downregulation of potassium channels, conditional, potassium channels, and this could predispose to epilepsy. So astrocytes are another interesting part of the neuronal cells, and they are integral part of neuronal transmission, and some drugs in the future could target also as astrocytes. Recently there was a silganersen which is now being developed for the treatment of Alexander's disease, that is also to some extent a seizure disorder, and it actually targets GFAP antisense nucleotides. This means that it will try to change the astrocyte function and thus treat epilepsy. So this is the epilepsy pharmacology is an ongoing process, and we already have lots of drugs on the market that are safe and effective, but this is just to show you that this is still an active area of research and new drugs might target even very novel and very different pathways in the brain. So anti-seizure drugs can be roughly also classified for the what kind of treatment they can be used. So carbamazepine and valproic acid are quite broad-spectrum antiepileptics. Some anti-epileptic drugs are very narrow use, like etoxasamine. They're used only for absence seizures. Clonazepam is more specified for myoclonic seizures, and there are lots of novel anti-epileptic drugs, including gabapentin, that can be used as adjuncts to the treatment of epilepsy. Parkinson's disease. So Parkinson's disease is a slowly progressive degenerative disorder characterized by resting tremors, stiffness, rigidity, slow and decreased movement, and eventually gait and or postural instability. Diagnosis is based on history and physical examination, and the treatment aims to restore dopaminergic function in the brain with levodopa plus carbidopa and or other medications such as dopamine agonist, monoamine oxidase type B inhibitors such as amantadine, and for refractory symptoms in patients without dementia, stereotactic deep brain stimulation or lesional surgery and levodopa can be prescribed. So currently and mainly, Parkinsonism treatment focuses on levodopa and carbidopa, and this is the main way how we can treat bradykinesia and Parkinsonism. However, there are some adjunct therapies such as dopamine agonists like pramipexole and ropinirole that stimulate dopamine receptors and can be used early in younger patients to delay levodopa-related complications and or later smooth muscle fluctuations. MAO-B inhibitors like selegiline can prolong levodopa's effect, while COMT inhibitors like entacapone, tolcapone extend levodopa's duration of action and are especially helpful when the benefit begins to wear off. This is important because when you prescribe levodopa as a standalone, on-off phenomena develops. That means that patient has fluctuating Parkinsonism. This means it feels Parkinsonism and gait disturbance, then you prescribe levodopa and then the effect ceases. So we want this treatment to have a durable effect, not just like on-off, because that's not convenient for the patient. Also, beyond medications, there's possibility to do exercise and prescribe supportive treatment strategies. So dopaminergic transmission occurs in nucleus caudatus, putamen, globus pallidus, and substantia nigra. Substantia nigra creates dopamine, and this is where the pathology of the Parkinsonism resides. Of course, of note, it's important to know that antipsychotic drugs inhibit this as well, signaling pathway, and this is why you can get drug-induced Parkinsonism disease in patients who are being prescribed antipsychotics. So yeah, the treatment is also you can treat the medical-induced Parkinsonism with cyclodol, an anticholinergic drug. So, clinical pharmacology of antiarrhythmic drugs. Very brief introduction. Antiarrhythmic, it's important to classify arrhythmias into bradyarrhythmias and tachyarrhythmias. So, tachyarrhythmias can be supraventricular or ventricular. So, from supraventricular, atrial fibrillation and atrial flutter are very common, and they happen when fibrosis occurs in synatrial node, and synatrial node is no longer capable of producing proper depolarization to control the heart rate. As fibrosis progresses, atria dilate, and with time and progress, atrial fibrillation becomes a standing and chronic condition that cannot be cardioverted. So the treatment of atrial fibrillation focuses on rate or rhythm control. Rate control implies using such drugs like beta blockers like metoprolol or calcium channel blockers like verapamil to control rate. And if we want to do cardioversion, we can prescribe propafenone or amiodarone. Broadly and roughly, we classify antiarrhythmic drugs into class 1A like quinidine, procainamide, and disopyramide. And these class 1 drugs are sodium channel blockers. Class 1B drug is lidocaine, that's sometimes still used in the resuscitation algorithms. And maybe the most important part will be the class 1C drugs that are propafenone, for instance. They are also acting on sodium channels or can be used for Wolff-Parkinson-White syndrome. And propafenone has interesting properties. First and foremost, it actually has interesting broad contraindication, structural heart disease, because it can provoke arrhythmias and other adverse events in these patients. So easy to remember is that propafenone can be prescribed for healthy patients with atrial fibrillation. Also, propafenone has an interesting property is that you can restore sinus rhythm with propafenone when the patient has propafenone. So you can prescribe double the dose and restore the sinus rhythm. So that's a convenient way to treat atrial fibrillation. Class 2 drugs are beta blockers like metoprolol. They are used only for rate control. Class 3 drugs is amiodarone, sotalol. They block potassium channels, prolong repolarization and refractory periods, and reduce cardiac excitability. They are used mostly for cardioversion. This means you identify that the patient has rapid onset atrial fibrillation, that has symptom onset below ideally 24 hours. Then you do anticoagulation and cardioversion with amiodarone after correcting potassium, sodium, and other electrolyte anomalies if they are present. In some cases, you will note that some cardiologists try to have potassium levels at least 4.5 millimoles liter. This means higher normal in patients with atrial fibrillation. There are also other drugs such as digoxin, adenosine, and or electrolyte supplements such as magnesium and potassium. So digoxin increases contractility in the heart and blocks atrioventricular node by increasing calcium levels in the cardiac muscle cells. So this leads to decreased heart rate and also decreases symptoms of heart failure. So that's a very good drug in patients who have atrial fibrillation and heart failure. It's a very old drug, but also it's a narrow index therapeutic drug, so it can be easily overdosed. Despite the benefits of antiarrhythmic drugs, they also carry significant risk. Most notably, they can themselves cause proarrhythmic effects. Many can also lead to bradycardia, conduction blocks, and hypotension, especially if combined with cardiovascular or psychotropic drugs. Some actually drugs have specific toxicity, such as amiodarone can affect the thyroid, lungs, and eyes, or beta blockers may worsen asthma or COPD. And calcium channel blockers can cause constipation, edema, and gum overgrowth. So whenever prescribing antiarrhythmics, you need to be wary and monitor the patient accordingly. Antithrombotic drugs. So this is a simplified clotting cascade, and we can roughly classify anticoagulants into vitamin K antagonists, factor Xa inhibitors, direct thrombin inhibitors, and low molecular weight heparins. Now, heparin, if it's unfractionated, it is an old drug. It's used as an anticoagulant mostly in pulmonary embolism and or deep venous thromboembolism, but it is administered usually intravenously with automatic pump, and you need to monitor APTT levels that need to be above 1.5, 2 times the baseline. Renal elimination is not important for heparin, so that's why it's a convenient drug. Low molecular weight heparins are more specific to factor Xa, and they are more convenient to dose because they do not need activated partial thromboplasin monitoring, and they can be injected subcutaneously. For instance, twice daily, and you don't need a standing infusion just like heparin needs. Heparin, low molecular weight heparins can be used for prophylaxis or treatment of thromboembolic conditions. Direct oral anticoagulants, rivaroxaban, apixaban, they act on factor 10A, and dabigatran binds to thrombin. And they are used to treat deep vein thrombosis, pulmonary embolism, and atrial fibrillation. Of note, low molecular weight heparins and heparins are not used for anticoagulation in atrial fibrillation. Vitamin K antagonist is warfarin, and it's used can be used for pulmonary embolism treatment and or treatment of atrial fibrillation. But nowadays, in more advanced societies, warfarin is being used for the treatment of mostly valvular atrial fibrillation. Now, small recaps on what we're doing here and what. So, if you have a patient with atrial fibrillation, you need to write an ECG, check for RR intervals, and look for P waves, F waves, and if you cannot see P waves or see atrial flutter and or RR irregular intervals, then you can diagnose atrial fibrillation. Then the second point is you need to differentiate whether it's acute or non-acute occurrence, because it could be that the patient has long-standing atrial fibrillation, and sometimes you need to do really nothing with such patients. But let's say this is acute atrial fibrillation that has never been registered before for the patient. So you try attempt cardioversion, because patient with atrial fibrillation will present to emergency department with anxiety, fear, palpitations, and fear, to the emergency department. And in such case, when in doubt, you can decrease heart rate with metoprolol, like a beta blocker, or verapamil calcium channel blocker. While doing so, you decrease the heart rate and decrease the symptoms, and the patient has really gets lower amount of anxiety and feels better. But if its onset is less than 48 hours, or even better, less than 24 hours, you need to attempt cardioversion if the patient agrees, because patients, when they present to emergency department, if they have palpitations and or irregular heart rate, they will feel distressed about that. And so to increase the quality of life, we need to attempt cardioversion. This means that you do anticoagulation and can prescribe amiodarone and monitor QTC levels, QTC interval in ECG, and also monitor if the sinus rhythm is restored. Now, while doing that, you need to do anticoagulation. During or in hospital, you could attempt low molecular weight heparins or heparins, but generally the only accepted approach for the atrial fibrillation treatment and anticoagulation that has all the evidence is anticoagulation with direct oral anticoagulants or warfarin. Warfarin is less convenient because it takes about 3 days to get its full effect, and also you need to do the national normalized ratio and spiroprotein assays to monitor for therapeutic effect of warfarin. So it's very tedious and not convenient for patients. So you need to anticoagulate patients with atrial fibrillation, even if you manage to restore the sinus rhythm. So another approach, if the patient is healthy, you can attempt sinus rhythm restoration with propafenone. If this fails, you can do electrical cardioversion in intensive care department usually. But if you are uncertain about what's the timing about onset of atrial fibrillation, you need to do cardiac echoscopy to check for thrombus, and then if there is no thrombi, you can attempt cardioversion or anticoagulate for several weeks and attempt cardioversion. Still, each and every patient with atrial fibrillation needs to undergo cardiac echoscopy to check for cardiac pathology, for instance, increased HA, because if HAs are very increased, this shows pronounced fibrosis and synatrial node, and in such patients, the cardioversion is very likely to be not successful, and if this happens, the patients are left with atrial fibrillation. So almost every patient needs to be anticoagulated if they have atrial fibrillation. Now, there is this thing about bridging and anticoagulants. So it's an old idea, but before we had direct oral anticoagulants, we had only warfarin. So in cases like pulmonary embolism, when you diagnose it with chest CT and angiography, and you find pulmonary embolism, you would start patient on heparins or low molecular weight heparins and start saturation with warfarin even while on heparins. So you need to do this bridging in patients when you want to start them on warfarin, but if you are prescribing direct oral anticoagulants like rivaroxaban or dabigatran, just when you start treating pulmonary embolism and you know you will start treating then with rivaroxaban, then you treat for a week with low molecular weight heparin like natroparin or enoxaparin or heparin, and then after when you decide to prescribe rivaroxaban, you just instead of next dose of heparins, you prescribe rivaroxaban. Treatment of anticoagulation of pulmonary embolism is at least 6 months. Now, in atrial fibrillation, patients will receive lifelong anticoagulation, very likely. There have been attempts to anticoagulate patients with aspirin, nadoparin, aspirin, clopidogrel, and similar attempts. They are described in medical literature, but they are not used, because if you were to give just aspirin for a patient with atrial fibrillation, you will get ischemic stroke. So yeah, have fun studying, and I'll see you soon. So I want you now, guys, to go to Moodle and start solving situations. I will log in soon enough in about 30 minutes time, and we'll discuss what you found in the situations. Thank you.